I've been an industrial salesman. I started off as a janitor, worked in a very large, it was called Builders Emporium. They went bankrupt. That wasn't my fault.
In a place where overhead's just expensive. To be a doctor, you need the lawyers, you need revenue cycle managers, you need all this stuff to operate.
The economic relationship became more intertwined. Physicians either lost control or didn't desire to have control. I don't know, and I frankly don't care.
I think more competition would be good for hospitals. What's going on is it allows them to be inefficient and it allows them to treat people like shit.
That's demoralizing for someone who views themselves as a professional whose ultimate loyalty is to their patients, not to the facility or the institution.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Hello everyone, welcome to another episode of the Life of Flow podcast, and today we have another banger. We have Mark Weiss. How do you say that in German?
Mark Weiss.
Weiss?
Weiss, but he is Mark Weiss.
He is Mark Weiss. Mark is a lawyer who specializes in representing physicians and physician-led ventures, and he wrote a book that's called The Impending Death of the Hospital.
Fucking love it.
So, this right up Miguel's alley. He was eating it up. Hope you guys enjoy it.
It's a PDF. It's free. Download it. All the information's in the show. Stick around. It's a good one. All right, Mark. Well, we finally got you here. Been a little give and take in scheduling, but we are here and I am stoked. I'm going to say I'm a fan. I've been following your LinkedIn content and quite frankly, I'm the guy that goes triple like if you could, right? If there was
Appreciate that.
if there was a button next to the like that said fuck yeah, I'd be the guy that would be putting the FY on every one of your posts.
I'll see what we can do about that.
You will call LinkedIn.
You preach at least my truth, and I really appreciate that. And part of, I guess, what I wanted you to talk to us about is this book that you came up with, which I'm pretty sure the listeners are going to be really interested in, and more so the fact that you actually just give it for free, which is pretty amazing. But maybe let's set the stage. Give me a 60,000 foot view of your journey professionally, and how it accelerate to the book as to how you got to a position where you thought writing this book was the right thing to do, and now certainly promoting this book, which I think is very timely.
All right. So if you want the 60,000 foot view of me, we'll start at a point slightly after I hit puberty. But I am principally a lawyer, although I have some other
good part.
Oh yeah. So okay, well yeah. So I'm principally a lawyer, although I have some other interests in healthcare, which are probably outside of this discussion. But I think what's important to know is that before I went to law school, and even when I was there, I've had other interests in terms of employment, right? So I've been an industrial salesman. I started off as a janitor in a factory working after hours. I worked at, McDonald's. I worked in a very large, it was called Builders Emporium. They went bankrupt. That wasn't my fault. I keep having to say that. It wasn't my fault. It was it was a chain of large hardware stores in Los Angeles. So I've had a lot of kinds of jobs, which informs my thinking and it informs the kind of things I like to do. So anyway, I went to law school, became a lawyer, and started off doing litigation because that's where, there's a lot of work in law firms to do litigation. I didn't particularly like it. I like going to court because you met your friends there, right? And you hung out, and for a 45-second appearance, on some motion, it took 4 hours, and so it was easy to bill for all that. But over time, it just wasn't for me. I became basically a real estate lawyer doing deals. Among my clients doing real estate deals were physician partnerships of physicians who initially acquired small facilities, such as skilled nursing facilities, and over time built up until they had developed many acute care hospitals. And then at some point before I met them, they got out of the operation of the hospitals and became landlords. In the 1980s, probably, before you guys were born, maybe not. Around 1986, 87, there was a recession. And I had built up a significant real estate practice, including those guys. And all of a sudden, real estate was going like down, right? Did you ever, when you were a kid, did you ever go to a department store and there's an escalator going down and you jump over onto the escalator going up, right? You just actually jump over. Not like in a Nordstrom where they put them like 20 feet apart, so you can't do that, but like in a May company. I think they went out of business too. But before I hit like bargain basement, I jumped over onto the up escalator. Principally, it was the same guys who I had met while doing real estate work for their hospitals, right? That they owned as real estate assets. And I became a healthcare lawyer. That work was, at least for the first 10 years, maybe more, was focused on physician deals, right? So it was representing, at that time, anesthesia groups, radiology groups, and probably every kind of surgeon and some internal medicine doctors that you could imagine. And it was all deal and regulatory oriented. There weren't as many regulations back then, but it was deal and regulatory oriented. And over that period of time, I developed a real liking for working with doctors because, especially even at that time, the initial anesthesia groups, for example, that's been a lot of my business. These were doctors who held medical staff privileges in common at a hospital that had no business function at all. And I was doing work taking groups from zero. There was no common business structure to, well, in some cases, $50 million in business, basically overnight. I mean, they didn't get to 50 overnight, but by the end of the year or 2 years, they were at 50 million. These were large groups. So working with those guys was fun. I liked their personalities. I liked their purpose in life. Many of them back then, I think, had more of a business head than many doctors today. We could talk about my experience having been a volunteer assistant clinical professor of anesthesiology at USC's medical school. Because I know, people say, you had that professorship. Are you an anesthesiologist? And I say, it's a great joke. Why? No, it's a softball. It's no, I can put you to sleep, but I can't wake you up. So, I enjoyed working with them. I enjoyed helping physicians create something that helped others. And that's how I got into this line of work. And it's basically it is the entire law practice, right? And if you look at the split, it's probably 75 to 80% hospital-based groups, including new ones that are forming now. And the rest, ENTs, orthopedic surgeons, dermatologists. I mean, the list goes on. I don't think I've represented a proctologist yet, though, but there's always tomorrow.
So when Miguel introduced you as one of the guests, I was kind of excited. And one of the topics that we talked about was some of the content you put out on the death of the hospital being a bloated corpse. Dive into that. Why do you think that is? And where's it going?
Okay, so that ties into my book, which, of course, I have a copy of.
What's the name of your book?
So this is called The Impending Death of Hospitals.
Okay.
And if you go to listeners, watchers can get a copy for free and PDF at my website, which is Weiss, like my name, WEISS, PC, like professionalcorporation.com. And there's some other books there and a whole bunch of other free materials. Or if they really want to, these things are sold on Amazon, but it's the same book. You can go get it for free if you like PDFs. This book addresses a central point in my practice and what I've observed in terms of representing physicians, both, hospital-based physicians and office practice physicians since, I guess, really 1983, maybe even before that. And that is that the relationship between the relationship between physicians and hospitals developed over time, and for many years it was symbiotic. In fact, the first hospitals in the United States, at least, were extensions of medical practice. Uh, they were the place where physicians had privileges, and they were the place where patients who couldn't be treated at home were put for treatment, right? And over time, hospitals became larger and larger, in part because the technology at the time, right? If you needed to monitor patients, putting a whole bunch of them in some ward was a lot, better and easier than, individually. Uh, but what also happened over time is that physicians began to become, in essence, owned by hospitals. The uh, economic relationship became more intertwined, and physicians either lost control or didn't desire to have control. I don't know, and I frankly don't care.
Mark,
Yeah.
when we go back in time, don't you think that the exodus, because when you look at the last 20 years, the amount of independent physicians has staggeringly gone down. It is my understanding that mostly fueled by a never-ending cut strategy by CMS that has essentially made it in a in a in a in a place where overhead's just expensive, right? To be a doctor, you need the lawyers, you need the rest, revenue cycle managers, you need all this stuff to operate. But still, I'd say 20 years ago, there was a significant margin that would allow you to operate inexpensive. But CMS takes some decisions that essentially empowers the hospital, gives them a lot more money for the same procedures, no matter where you do them. So if you have an ASC, the hospital's going to get incentives. That all is kind of shifting. But I believe that when it's first favored massively, the hospital systems, it essentially drove physicians out of business. And on top of that, they got then kneeled in the groins when the only potential move is, okay, well, then be the owner of a hospital. And then that got vetoed, right? Then right now, to our previous conversation, even a janitor who's a felon can own a hospital, not a physician. And so they drove physicians out of private practice, out of independent practice, and into the hospital. And then with that, the beginning of the end of autonomy, and certainly all the other repercussions that come down the line. But do you see any other things that accelerated that, or do you think that's kind of the cataclysmic problem that just torpedoed this whole avalanche?
Okay, I think that those elements are the driving forces, but I think there are other elements, and I think that physicians should think about what the other elements are. So first of all, uh, before the huge move to make hospital reimbursement, including reimbursement to hospitals that became, quote, health systems that included physician services, more profitable, or why don't we say to have higher sort of reimbursement in payments to physicians, there was an earlier event that helped push physicians from the notion of practices are independent to practices are much larger, and that was the initial growth of managed care and of managed care medical groups, right? So some of those sort of still exist in the sense of the Permanente Medical Group and Kaiser, which is I mean, this is probably from the 1940s, but certainly in the 1980s in California, where I was practicing solely at that time, there was a push to acquire/employ physicians, pulling them into large models, whether they were employment models directly or through intermediary entities, so-called like foundation models, So there was a consolidation movement at the time that many physicians found attractive because it alleviated the hassles of running their own practice. So this is sort of a priming. Now, I don't think this is like part of some giant conspiracy, right? But it is a fact that even then, physicians were prone to the line, which was, you didn't go to medical school to learn how to run a business. Let us run it for you, right? Which is the line, right? Now, the line may turn out to be a lie, but that line existed before. So that's number one. Number two, when I started volunteering as the assistant clinical professor at USC, teaching like a survey course on the business and legal issues of medicine, right, and to medical residents and a lot of attendings who were coming to get free legal advice. Uh, Even back then, many of the students were professing no interest, even in becoming an owner of a group. I don't particularly want to become a partner in some group or a shareholder in some group. I just want to get paid. Mark, do you think I'm going on a first interview? Do you think I should ask about how much vacation time I get on my first interview? It's like, are you fucking crazy? But so there was some sort of a societal shift there, right? And I think that fueled some of this. Now, certainly, the federal government.
What year was that? Sorry, what year did you start
When
noticing
that
that shift?
started, that was in the 1990s. I forget what year, but I mean, clearly that was going on then. So the the shift in sort of payment policy to the whole notion that the government was going to reimburse this for the same service, the same physician service, higher at a hospital as opposed to in a physician's office, began screwing physicians over and began building the ability of hospitals to outcompete physicians, to hire physicians, to tell physicians, come join us, either directly or indirectly, depending on the state's laws concerning corporate practice of medicine. And we'll be able to pay you just as much or more. We'll run the business. That began a shift. Now, in many cases, this turns out not to be true. I don't know how many, well, I don't know how many you've spoken to said I fell for that, and now it turned out not to be the case. But hey, that's the line. But it is certainly the case that if Mrs. Smith goes to a cardiologist in January, and the cardiologist is independent and has some test and gets a bill for $300 at the office, and then is told, make an appointment in 6 months, we're going to repeat the test, comes back, and in between, that cardiology practice has been acquired by Happy Hospital of the Valley. Happy Hospital is now going to charge, in addition to the fee for the physician services, they're going to charge a facility fee, and Mrs. Smith is going to walk out with some bill of, $800 as opposed to whatever else she paid, $200. I forget if I even mentioned something. So that has resulted in an economic reward for hospitals to gobble up physician practices. And I don't know, depending on the specialty, it's 50 to probably 80% of some specialties are in essence owned by hospitals. And it becomes difficult to escape. It becomes difficult both in terms of whatever state law provides for, in terms of covenants not to compete, and it becomes difficult emotionally and financially, but mostly emotionally. I think a lot of the physician's fear of starting my own practice is fear, right? And fear is a very powerful factor, and fear, I think, is used.
What have do you work with residents now? Because just as a insight into something you just said, you know, Miguel lives here in Houston, you live in Dallas, I live in Austin. Probably very strong entrepreneurial cultures. a lot of the people I interact with outside of medicine are in like their vision is to build something. The one place I don't see that in a cohort of young people is in the residents I work with. Very few of them, I would say, have an entrepreneurial mindset and kind of long for the golden handcuff. So I wonder where that comes from and what the sub-selection is of people.
Okay, well, in my experience with which anyone would say is purely anecdotal because that like N is going to be hundreds, it's not, hundreds of thousands, right?
Yeah.
Um, in my experience, most physicians in residency are interested in practicing medicine. We'll do that. We'll do a one split here. Practicing medicine as opposed to doing something that other people at that stage of education, but in some other track, I don't know, physics, mathematics, maybe thinking, I am going to take what I've learned and I'm going to go and I'm going to create some startup that is going to create, an even better electronic medical record and even better, don't ask me, pacemaker, be my guess. I don't know. Number two, I think the mindset of many people in their 30s, right? My own son is a dermatologist. This is his first year of practice, right? And so I could use him as my guinea pig, and if he watches this, he'll get pissed off. So we won't use his actual name. But the notion of starting a practice is like, what? It's go get a job someplace. And now part of that might be, well, I need to know what it's like to practice. They didn't really teach me what it's like to practice. So maybe in 4 or 5 years. But the notion of leaving residency and starting a practice is rare. Now, that said, I have represented people who have done that, who have left their residency and started a practice. But those folks are far and few between. There's a similar phenomenon.
All the ones that I know that have done that have been successful.
You see, because they just took a leap.
That went straight out.
Yeah.
Yeah. They've been doing really well.
The guy that went down to El Paso, what's his name? Shout out to
Garza.
Yeah.
Successful. Yeah, where I see it, the disconformity with that come to Jesus, where you realize that you put all this effort to do this one thing and you reach that goal, and it sure seems like the one thing you always thought you needed was the one thing you don't need. It's somewhere between the 38 to the 48-year-old mark where you're like mid-career, 10, 15 years into it. And you look back and you go home and you sit and you say, WTF am I doing? I hate my life. I hate having to be in these committees. I hate having to present my flu shot every year and having to tell the CNO that I know how to wash my hands. Because every year I have to do another training course to do what I've been doing since I've been 2 years old. And idiocy after idiocy, and if you've had to deal with the medical executive committee, things even are worse because you fucked up for some reason on some dumb shit that just gets completely out of proportion because everybody and their family members get involved in trying to pass judgment and figure out how you have to be reprimanded and how the hospital has to come out of this understanding that you're a bad, rotten apple. Anyway, I went down this dark rabbit hole, but it is really when all these things happen. And I don't see this at the early stage, but I see the disconformity with the systemic oppression in the mid-careers. Is that also what you've noticed, Mark?
Well, I think that is the point where most people either stay on the track that they're on and don't do anything to ever get off the track, although some things might happen to them that force them off the track, which is a different story, right? In other words, they become an involuntary entrepreneur or their career gets whacked and all of a sudden they're doing something else. Or they say to themselves, this is the time to make the change before I become so entrenched that I know that I will not be able to make myself escape the track, right? So if you have 4 kids in private school and your fear is that you might starve, you're going to stay on your track. And there's some people who just don't have, and it's not a defect. There's some people who don't care to become an entrepreneur, even if they have 3 partners in doing it. They just, that's not in them. And that's not right or wrong, right? I mean, right? So, I mean, if everybody wanted to be a vascular surgeon, you guys would be starving to death.
Yeah.
Through that.
So,
So,
right?
let's get back on track with
Yeah.
what has then conspired 20 years to today. So from 2000 to today, with the massive pull in of all these physicians, and I want to say the statistics are independent physicians are under 10% at this point. I think I may be
Yeah, I don't think it's that low, but it's low.
it's significantly
It's low.
yeah.
Yeah.
What because by all metrics, when we look at objective data, the care hasn't gotten better.
No.
The price point of care has spiraled out of proportion. I mean, Medicare is essentially has no funds, right? Unless they have to keep doing bill after bill after bill
Right.
to continue maintaining our society. So, what do you think has been happening to get to this point that I guess in many ways you touch in your book, which is the impending doom of these hospitals?
Well, you see, um, one large factor in the continued sort of primacy of hospitals and the continuing consolidation of physician practices, which ends up, well, there's, which is a reason for a lot of the consolidation of physicians into employment models. I mean, there are other models, right? That there's very large medical groups, the practice management company sorts of models. We could talk about that. That's really a separate sort of issue. But on the hospital side, is sort of importantly intertwined with Obamacare and the support that the American Hospital Association threw behind the passage of Obamacare in exchange for a legislative, quote, permanent. I mean, no legislation is permanent; it can always be undone. But a legislative um, um, requirement concerning physician ownership of hospitals that participate in Medicare. So by limiting, number one, by paying hospitals more when physicians are rendering services through an entity that is controlled by the hospital, and 2, by then preventing physicians from, we'll just say owning, it's not exactly the case, but from owning hospitals that participate in Medicare. Hospitals have locked in their position, a position that enables them to better compete against physicians who are independent, and 2, that prevents many physicians from playing the same game, right? Vis-a-vis Medicare. Now, that's not to say that there are not physicians out there who are creating hospitals that are not participating in Medicare, because there's no law that you can't do that. And now, unless we start talking about certificate of need that exists in some states and blah, 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 these are other issues, right? So it's sort of, there's lots of factors going on here depending on where you are.
What do you say that's like the most un-American thing ever to like?
Well,
Yeah,
yeah, it's interesting.
Yeah.
It's so funny. It's like you read sticky notes that I write for myself about
Yeah.
topics, or a certificate of need. It's like asking the supermarket chains that have stores on 2 corners whether somebody should be able to open another market across the street.
Yeah,
Hell
they can
no.
open like a farmer's market or something, asking
Right.
like,
Right. So
Jeffrey
it's nuts.
Whole Foods.
Yes.
Yeah.
Right. And the line is that, well, hospitals are going to fail if we have too much competition. That's the line. But I think the line is a lie. I think the certificate of need, I mean, I wrote some article about this. It's like people call it a con, and it is a con.
Well,
It's as in a confidence game. It's a
shouldn't
con.
they fail if they can't compete to provide value in society?
That's correct. I think so. But I'm like a free market guy. But we don't live in a free market society, just despite what somebody might be protesting with a placard. It's like this is sort of a semi-managed economy. It's not a free market economy.
I don't think physicians realize this. I want to just pause and say we got kicked in the shin, and then they, like Mortal Kombat, just got beheaded when they took our privilege to own. No, think about it, man. I mean, it's from a tactical standpoint,
Yeah.
it's pretty freaking brilliant that
Well,
they took the motor. We are the motor of healthcare, right? I mean, if
Yeah.
you don't put your CPT codes, nothing moves.
Yeah.
But then they took your own wings and they clip, clip, clip. And then we all were like, okay, then I guess we're gonna stick here, and then they'll treat us like
Yeah.
because we're not assets,
No, I know.
we're liabilities.
But
You
like
know that, right?
I don't like the because I understand what you're saying, but I think there's like a victim mindset in what you're saying that somebody did this to us. What I'm thinking is like I am so fucking ignorant about everything. Like we've had you on, we've
You
had
know, somebody
Dutch
did
has
do sorry,
I get
somebody
it.
did do this to us. The problem is we had our heads up our asses
Yes.
and didn't notice it, and
And
still today have no single united voice that can fight financially at the level of what a lot of these people on the Hill are doing on a daily basis.
I think it's deeper. I think that there's something at a deeper level where there is a degree of arrogance and hubris that we have just because we learned to do one particular thing that's really hard, really well. And then I bet that if you ask a bunch of people that are not in independent practice about all these things, a lot of people are going to brush you off and just say, kind of decrease the importance of this. Because I could have found myself in that a couple of years ago in that group, and I probably think that a large percentage, probably more than 30% of us would kind of dismiss all this information. And that's on us. Because I think we first have to be aware of our circumstances before, like, if you're not even aware, if you don't even put the energy for the importance, then it's difficult to blame someone else. Although it's easy to blame someone else.
Well, to toss in my 4 cents worth here, while I think it is interesting to discuss how things got to where they are, I think a more fruitful question is, well, screw how they got to where they are now. What could we or because I don't think there is really a collective we solution to this. I mean, other than people voting, blah, blah, blah. I think what is required is for individuals who don't like the system to do something about it other than bitching about it, right? So each of you have told me that you've done something about it. So many people don't think it's impossible. I mean, how could I ever do it? Right? This is what they say. How could, I ever blah, blah, blah. I mean, even my own internist was a guy who sold his practice to a large hospital chain. He became part of one of those clinics where all of a sudden there was a facility fee, right? When you showed up to say hello to him, right? I got charged a facility fee. I mean, there's some great jokes about hospitals and facility fees. On my blog, there's a story about a woman who's going to the hospital to deliver a baby. She doesn't get there in time. The baby is delivered like in a cab by like the husband or something. And then they take her into the hospital, but they charged her for use of labor and delivery room, even though the baby was born in the parking lot. Doctors who make who do telehealth, consultations, like over a phone while they're in the hospital, as opposed to from their office, and the hospital charges them facility fees. We got all kinds of jokes about this, but I don't even know how I got to this point. But my point here is that, the internist. So one day he just had enough, and decided he was going to leave. And yeah, so he found somebody who was basically a not I don't have my hands in your pocket practice management company to help him get started. That lasted a year or so, and they said, I don't even need them, right? He has his own little staff of like 3 people. He has another doctor who's in his suite, so he doesn't have to be on call 24 hours a day, 365 days a year. He's making a ton more money than he did before. He has a real life, but I don't even think he thought, right, that he'd ever do that. See, because he started off in a practice group that he got some money when he sold, but then they began, ratcheting down, right? If something broke, you needed to fill in 3 forms to get one, and he became a cog. But he acted, right? So there are others that have done it. Maybe what physicians need is more sort of proof of concept, right? And maybe that has to come from other people who made the leap, right? It's one thing for some practice management company that's going to charge a percentage to say, we can help you do it. It's something else for, Miguel to say, I did it and look at me. I'm now rich and successful and I get dressed up when I go to work.
I don't.
Or I don't have to get. I don't have to get dressed up when I go to work. Yeah.
I wear my boots now because I got written up for wearing jeans once. Can you imagine that?
I remember you were pissed.
Do you remember that shit? That bullshit? Please wear professional, like some shit like that. It's a Sunday.
Yeah.
Get out of my. Anyway,
Yeah.
Mark, you alluded to very superficially, but I want to just make sure that I'm not missing something. You said I don't think that you guys are in a position where this unity can happen. Is it your thought that as physicians we're just not going to get our shit together to create a unified voice and maybe some political torque at the Hill?
I think that I think the problem is this. I think that physicians tend not to put their money where their mouth is, and it is difficult to. This is based on only my experience in terms of how many clients are members of sort of local medical societies, but not like state ones or national ones, because why pay the dues? Um, so to the extent you need money for this, I think it's going to be difficult to get a number of physicians to chip in to lobby. Certainly, like the American Hospital Association, I don't know how many millions and millions of dollars they spend every year. It's public; you can go find that out, right? To lobby, but um, the we in terms of taking communal action, if it involves something short of money, I think you're going to get more support than if somebody has to go out of the pocket. Just my gut on this. I mean, shit, prove me wrong. I'd be happy for that to
No,
happen.
I like to hear that because, as a rebel or as an anarchist in a way, we're sometimes blinded by our message, right? We feel we're so empowered with the truth and that we know that this is what's right. And then it's good to hear when people say, good luck, buddy. Doctors don't put their money where their mouth is. And that's absolutely true. I've seen this multiple times in investment deals and other things. And I believe we're very selfish too. When it comes to, groups, there's a lot of fighting between societies, fighting between specialties. So to think that we're ever going to be able to put one jersey and have a voice is a tough one. But I will die trying. How about that?
Well,
That's fair.
the thing is, how do you do it, right? Because like, I don't. The SVS is never going to be a vehicle for our autonomy. Why? Because the people that run the SVS always ran large institutions. So right there's like Dr. Mills, which is
The
a
Society of Vascular Surgery leadership is the leadership of academic and grain hospitals. That's also not only get all the money, but then get all the federal and the tax breaks and all these multiple things that
so the perspective through which they view the world is completely different than the people that they graduate, right? So the people that graduate go out into, you know, into the real world, right? So there will never be a vehicle for us. So, but the thing is, like we were talking before the Truro has about all these impediments, like need for, what do you call it when you need certificate of need,
The con.
all these things. Yeah, so I think we get to shine a light into the places that isn't being done where it benefits us. So like in the 7 states where you don't need that, and really tell people this message. And eventually, over time, like physicians will gravitate to those places, but then the other states will probably have shortages and will want to bring physicians in. So then I think a local strategy where you convert first at the small level, fuck the national level, really, right? You're not going to win against Aetna, Sigma, all those people. You're not going to win, right? But you might win locally when you have true connections to your community, and then kind of, go from the bottom up. That's one way I think you can approach it, and just use pure incentives and, human nature, which is basically capitalism.
Well, related to that, there are other things that physicians who want to break free of that system can do, whether alone or it's probably emotionally safer and probably economically more wise to do so in collaboration with partners. And that is to create your own sort of practice world, including the facility world, outside of the hospital controlled structure, right? Which is ASCs or, office based lab kind of practice, or, uh, I'm not a big believer in the freestanding emergency room because I think it's almost a scam on patients who think it's an urgent care center and it's not. But, um, or even on the hospital side, right? So there are people that I'm working with who physicians, in particular a physician, who's involved in a structure in which a group of physicians acquired a an old physician-owned hospital, right? And so we're able to um, um, work within the structure that would otherwise prohibit them from owning a Medicare hospital, right? It was a physician-owned hospital and are modernizing it and then turning it together with a related sort of ASC and related other into their own little sort of healthcare, enterprise. It's sort of their own mini little healthcare system controlled by physicians. There are physicians who went, uh, head to head with hospitals by, uh, have you spoken with any of the people involved in what's called I think it's called the Free Market Medical Society, the Free Market Medical Association? I'm going to blank on his last name. There's a guy, he's a doctor, Keith, and I'm sorry, I'm blanking on his last name, but I'll send it to you. Uh, was an anesthesiologist in Oklahoma City, and these guys put together, uh, probably 15 years ago, maybe more, an ASC that is basically uh, cash based, and they quote prices for the whole procedure. Now, I think there's some tiny little things that are not included, but basically, it's the facility fee, it's the anesthesia, it's the surgeon, right? It's all a global fee, and they've got a website with like a little body, and they're like, where does it hurt? Here, oh, ganglion cyst that costs. I'm making this up. 3x or whatever. So the hospital can't compete with this. And so there are ways to think outside of the hospital box, but you have to get over that emotional hurdle, which is it's not possible to get out of the hospital box, but it is.
There's a significant change of winds, I think, with this particular government. Um, Site payment neutrality being one of the things that they're really pushing for. And the intentionality of now Medicare, I think, to drive costs down by moving care outside of the hospitals. And I think for this reason, there has been um, a more contemporary intention placed in creating more opportunity for physicians. And now more than ever, with what seems to be the first time in history that there are plans to turn over this rule of law that that doesn't let us own hospitals. So it seems like there's a pretty significant shift happening here in as little as 12 months.
Well, people have been talking about site neutrality for a lot longer than 12 months. Whether the Trump administration does something to act on it, that's a different story. But you're 100% right. It's not just the federal government. I mean, even several years ago, private payers began pushing out of hospitals outpatient imaging. So why does Mrs. Smith have to go to a hospital, walk in, get some X-ray or some scan and walk out? Why can't this be done at a freestanding facility where what the carrier, the payer, is going to pay us so much less? And the answer is, well, they're pushing that out, and that was a huge, boon for physician-owned. It didn't matter who owned them, freestanding imaging facilities, right? The quality is the same. The cost is less. Have I ever been a patient in a hospital? Only as an outpatient. But I know that other than going to a hospital as a lawyer to see clients, right, or to go negotiate some agreement, I don't like being in them because they're filled with sick people and I might catch something, as opposed to going to some imaging facility. And look, on the ASC side, right, it costs less. Doctors can legally profit, fewer infections. They're a lot nicer because assholes don't last at those places as employees because they screw up the whole process of work. It's a much more pleasant experience. Why not do that? So there are certainly ways for physicians to compete with physician-owned, vehicles. Not in
You
every
think this is
area,
going to
but in many.
fuel your concept of hospitals being in trouble? If we push site neutrality and we stimulate outpatient care by private payers and managed care, that's going to be a kick in the nuts for the
Oh,
hospital.
absolutely. I mean, I think there's this convergence of factors. Number one, it's any procedure that can be done as safe, or certainly more safely, outside of a hospital will eventually be done outside of a hospital. Number two, any procedure that can be done for less money will be done outside of a hospital. As technology improves, then the need to take somebody into a hospital where the technology exists and now can be deployed because it's so gigantic and so expensive, to the extent it can be moved outside, that's another win. So hospitals are facing, plus hospitals have, huge staffing issues, right? And again, I'm sorry, I can't remember Keith's last name, the physician who has this surgery center of Oklahoma City, but he talks about, well, if a light bulb goes out in their surgery center, he gets up on a ladder and he changes it. He doesn't call, some administrator who calls, plant management, who sends a janitor, right? Like next Tuesday, you just go fix it, put in a light bulb.
But I think more competition would be good for hospitals because they would have to compete. I think what's going on is it allows them to be inefficient and it allows them to treat people like shit, and not value the employees that value working there. There's so many employees that work that are cath lab techs, that are anesthesia techs, all these people that make things run, that really value what they do and really have strive purpose, but it just eats them that they're just treated as completely like
Oh, but
indispensable.
they get free pizza, man, when they have to do more overtime than they
No,
want to.
dude, not real. Like, dude, like people
I'm
want
telling
to,
you,
people
I'm
would
telling you,
work.
in
Yeah,
an absolutely,
yeah.
like,
No, no,
that's what they do. They bring boxes of
I
pizza
know. To
to incentivize the morale.
yeah.
Are you kidding me?
Fuck off with the pizza. Treat people like human beings and value them, and fucking like throw that pizza away.
Oh, the petty
Yeah.
pizza move.
Yeah.
I cannot with the pizza move.
So I think that if they have more competition, they'll fire a lot of their administration, which is probably leading to a lot of inefficiencies. You hire more people to make more rules, to make things more slower, add more friction, and then you value the people that drive your culture, which are the people that work there every day, the nurses, the techs, the physicians, and then that will allow them to do a better job and provide a better service.
Well, related to that, we can tie this back to um, to the point at which hospitals began acquiring physicians. And then I link that back to the early growth of managed care sort of practice entities, certainly in California in the 1980s. And one of the things that you noticed when managed care grew, think um, of internal medicine sort of clinics that are owned by a hospital. So you're going and you see a Dr. A. 6 months later, you go and to make your appointment, and they say, "Well, Dr. A is no longer here. We'll make an appointment with Dr. B." So you see Dr. B. 6 months later, Dr. B is gone. Now, what they did is, and what hospitals still attempt to do, is view most physicians as fungible. Right? It's like waiters in a restaurant, or I hate to say it, right? It's like, well, we want good waiters. We don't want shitty waiters. But if A isn't available, there should be B, because when A leaves, we don't want A taking anything with him or her. And I think that has helped create a lot of the unhappiness among physicians. They're not viewed by hospitals, not all of them, of course, and not all physicians, and not all hospitals, and not all hospital administrators, but many. They don't view them as valuable, sort of independent professionals, even though they might be getting a paycheck. They view them as part of the workforce. And that's demoralizing for someone who views themselves as a professional whose ultimate loyalty is to their patients, not to the facility or the institution or the whatever in hell you want to call
Well,
it.
in spreadsheets, your liabilities. So you have assets and
Yes.
liabilities. The CAT
Yes.
scanner is an asset because the CAT
Yes.
scanner gets maintained. It has you pay a service and you maintain that asset. A physician is a liability. So that tells you everything you need to know. It's in black and white. It's in math. So yeah.
Mark, again, where can you get this PDF?
You can get it at Weiss, WEISS like Peter Charles.com. Just go to the website and you'll see on the homepage sort of clear links to download The Impending Death of Hospitals. And there's 4 or 5 other books there, and there's a zillion articles. And they're all free.
I love it. I downloaded it. I uploaded it to ChatGPT, and then I said, make bullet points that I can make action items for my life.
You know, you can
And now I'm using your book as a blueprint for my life.
you can also
Oh,
make it a
jeez.
podcast.
Jeez.
And listen to it as a podcast.
Yeah.
Well, I can improve your experience because we're doing a walk over hot coals right after I get off this call.
No way.
Come on, that was a Tony Robbins joke.
Okay.
Didn't you
I
get
was
that
like,
one? All right.
holy moly. All right. Well, listen, Mark, I really appreciate you coming on the show and sharing your knowledge. I hope this is the first and certainly not the last.
Mhm.
You bring a depth of knowledge on a topic that, we're not lawyers. And so I bet you that there's going to be a few times where we may call on you and say, hey, we need to make an emergency show and go,
I would,
deep on this
I
particular
would enjoy it.
topic.
It's even if you guys were to call and we weren't recording it and we weren't sticking it on YouTube, I enjoyed myself. So anytime,
Well, we appreciate that. I'll tell you
anytime.
one request that
Yeah.
already came through
Yeah.
from one of my colleagues is non-competes and
Mhm.
this whole
I'll be happy to talk about that.
pain in
Yeah.
the ass of private equity buying their
Yeah.
practice, how that deal went,
Eh,
how it soured, and
Uh-huh.
how my friend had to literally relocate his family because they
Yeah.
stuck it to him. And some people are
Mhm.
still fighting fights and legal battles and all
Yeah.
this shit. So I think that's a good topic that maybe in the next
Sure.
couple of months we should have you come back and let's nail that.
Whenever you want, I'm happy to talk about that or anything else that I know something about.
Awesome. Well, thank you,
All
Mark.
right.
God bless you, and we'll be
All right.
in touch, okay?
Thank you, Mark.
You got it. Okay. Take care.
Bye-bye. Ciao.